Hi, my name's Erin McHale, and I'm a third-year doctoral student at Wright State University School of Professional Psychology. Today I'll be discussing non-empirical research on the issue of opioid use disorder and pregnancy and opportunities for intervention. Please scan the QR code here for a link to our full professional research poster. Research has indicated that the prevalence of opioid use disorder during pregnancy has increased by 333% from the start of the opioid epidemic in the 1990s to 2018 and continues to grow each year. Further, through Medicaid, 39% of women within reproductive age were documented obtaining opioid prescriptions, and the prevalence of opioid use at delivery increased by 131% from 2010 to 2017. Following childbirth, return to opioid use in those who had discontinued once pregnant was recorded in 59 to 99% of individuals. Despite these statistics, clinical opioid exposure trials often exclude pregnant women from their samples due to safety and ethical concerns, and there's currently a gap in women-centered approaches to opioid use disorder treatment. As opioid drugs can cause feelings of euphoria and reduce pain intensity, they can become addictive in pregnant persons who often report lower back and pelvic pain, migraines, and myalgia, increasing their risk for opioid use disorder. Pregnant persons with opioid use disorder are more vulnerable to experiencing symptoms of depression, anxiety, PTSD, and polysubstance use, and were found to demonstrate limited knowledge about childcare and the impacts of opioids on fetal development. They are also at higher risk for preterm labor and delivery, miscarriage, abruptio placentae, which can cause vaginal bleeding and abdominal pain, heart complications, and death. Regarding fetal outcomes, opioid use during pregnancy is associated with placental insufficiency, which can restrict oxygen and nutrients from the fetus, low birth weight, neural tube and congenital heart defects, neonatal abstinence syndrome, which is where the baby experiences withdrawal symptoms after birth, and death. Medication-assisted treatment is the preferred treatment for pregnant persons with opioid use disorder and involves medication like methadone and buprenorphine, which prevent withdrawal symptoms and cravings by occupying opioid brain receptors. Medication-assisted treatment during pregnancy has been correlated with fewer delivery complications, higher treatment engagement, decreased risk for NAS, fewer instances of relapse and overdose, reduced crime and STI exposure, and improved overall functioning. Additionally, breastfeeding in women receiving medication-assisted treatment was associated with lower NAS severity, shorter hospital stays, and enhanced parent-infant attachments. Combined with medication-assisted treatment, a comprehensive approach that prioritizes both pregnant individuals and their fetuses is essential. Beginning interventions prior to delivery is recommended to start building trust with clinicians and prepare for the stress of balancing parenting with recovery management. Substance use, mental health, and STI screening is recommended during the first prenatal visit to improve maternal and fetal outcomes. And treatment should include psychosocial interventions like CBT, nutrition education, substance use counseling, contraceptive services, support groups, medication management, and non-opioid options for pregnancy and birth like physical therapy. Identifying potential barriers to treatment, such as affordable access, stigma, and fear of criminalization, is essential. And the patient navigation approach that aids pregnant persons in managing opioid use disorder treatment has been correlated with fewer overdoses, increased medication use, and higher intervention adherence. Increasing strength-based, women-centered, and relationship-focused interventions that support parent-child development are also recommended, as they've been associated with decreased maternal anxiety and depression, positive parenting, increased breastfeeding, and contraceptive use. So what are the takeaways? These findings highlight the importance of integrating biopsychosocial treatment to prioritize the unique needs of pregnant persons with opioid use disorder, address barriers to treatment, and combat societal stigma. This should involve providing woman-centered approaches, as research has indicated that only 40% of U.S. substance use treatment programs incorporate these interventions to consider gender-specific needs. Future research should also broaden client diversity and racial and ethnic identities, and increase clinical trials that assess OUD during pregnancy with maternal and fetal health in mind. And then here are my references. Thank you so much for listening.